Our next step for sepsis is sepsis itself, which is basically some of these symptoms. So we have some symptoms of systemic inflammatory response syndrome. So we're going to take that and doing a good assessment in a patient history, we have some sort of suspected or confirmed infection. Again, it could be something they've had a recent trauma, they've been sick lately, you know, maybe have a lot of cellulitis on their feet or bed sores or things like that. There's some way that we think that, yeah, there's definitely an infection. There's some sort of sign that shows us there's an infection and they're showing symptoms. Septic shock is going to be defined as sepsis. So we have our symptoms, we have a confirmed infection, but now we're also having hypotension. But it's not just hypotension as a sign. It's hypotension despite the fact that we've given them fluids. So we've tried to solve the hypotension, but they're not responding very well to it. Now we're definitely in septic shock. Now the problem with septic shock is as it continues, it's going to end up creating a low perfusion, as we talked before, and it's going to compound on itself. And what's going to happen is a multiple organ dysfunction syndrome, or MODS. So multiple organ dysfunction syndrome and septic shock with organ failure is basically that are going to be unable to recover. The liver begins to fail, the kidneys begin to fail, et cetera, et cetera, et cetera, and soon we'll have death. There's also a couple other scores out there like the Q-SOFA and things like that, but I'm not going to get into those too much because typically pre-hospital and ER still kind of follow the SEERS guidelines, but you may see a Q-SOFA type thing in like MedSurg or something like that. So again, this is very important as it's becoming more of a hotter topic, and we need to know how to treat these patients. So the first thing is for our treatment is going to be a good assessment. We need good patient assessment and great questioning. Look at the patient demographics and ask yourself, are they a susceptible population? Look for common complaints associated with infection. So things for like the urinary system, complaints of UTI, the respiratory system, things like pneumonia. Maybe they have some skin issues, so bed sores, wounds that aren't healing, cellulitis, things like that. Abdominal complaints, if they're having an acute abdomen, belly pain, this could be a sign to keep sepsis as a differential diagnosis. Some other symptoms that may be associated with these diagnoses. So for pulmonary, cough, shortness of breath, increased respiratory rate, abnormal lung sounds could lead us down the road that they have some sort of lung infection. Sepsis can be on our differential diagnosis. UTIs in the urinary system, again, pain, increased frequency or decreased frequency, discomfort with urination, blood in their urine, change in odor, flank pain. These are signs that we may have an infection. Gastrointestinal, again, abdominal pain, nausea, vomiting, diarrhea can all be part of our symptoms that can lead us to maybe there's an issue that sepsis could be part of our differential diagnosis. And we also want to know, have they had any signs of fevers? So ask them about sweats and chills. So what are we going to do for treatments when it comes to procedures and meds? Again, this is going to be something that we can treat and should start treating early on in the field. The first one is going to be making sure that we have a good report to give our nurses. Whether that is because you work for a system that has code sepsis, or when you do give your handoff report at the hospital, you've done such a great assessment that you can tell them, I think this patient is septic. Because again, it's been found that these patients will then get faster treatment, which is what they need. The first thing we're going to do, if we have a septic shock patient or someone that we believe is in sepsis, is we're going to give fluids. There's a lot of different theories about fluids and different amounts and stuff like that. But typically these patients, the one that seems to be about the middle point is about 30 milliliters per kilogram, which can be quite a bit. Now, I would be cautious with people with, things like congestive heart failure and pulmonary edema, but don't withhold fluids. Reassess your lung sounds before and during your fluids to make sure that you're not causing any worse pulmonary edema. But don't be afraid of it. What I would suggest is that a lot of these patients may not be responsive to fluids. So we want to make sure that we are checking and reassessing our patients. I like to titrate my fluids to a MAP of 65. So if we have a low MAP, let's try to get it up to 65. However, this needs to be patient specific. If we have someone who has a history of hypertension, especially one that's not very well treated, these patients may need a higher MAP. So make sure we're assessing for good signs of perfusion, such as warm extremities, increased mental status, capillary refill, and things like that. What I suggest when it comes to fluids too is that maybe you start out with something around 150 milliliters or so. Doesn't have to be anything specific, maybe 250. There's a lot of things out there about elevating the legs and watching end tidal to see if this will show if the patient's responsive to fluids. These are great in hospital. My personal opinion is I don't typically have an extra set of hands in the back of the truck to be able to hold someone's legs up. So get the person on end tidal, see where they're at, and then give them a bolus of about 150 to 250 milliliters and look for signs of increased perfusion. Does their end tidal go up? Do we have an increase in MAP? And do we have warm extremities, better capillary refill, increase in color, or mental status? If this is working, keep on the fluids. If not, don't be afraid of vasopressors. So if you think this patient is not responding well to your fluids, call for vasopressors, because that's what they're going to end up needing. And we can start these a lot faster in the hospital. So that's the end of this immune system talk. We also talked about anaphylaxis and sepsis as it comes to when the immune system goes awry. If you have any questions, please reach out and ask me. Thank you.